Good morning, Chairman, members, and guests. My name is Precious Moman, and I'm a rising second-year medical student at the David Geffen School of Medicine at UCLA. Today, I will be presenting our project, Outcomes and Resource Utilization, following surgery for gynecologic malignancies at safety net hospitals across the United States. Safety net hospitals are defined as facilities that operate in low-resource settings, providing essential care to uninsured and underinsured patients. Previous studies have shown safety net hospitals provided poor surgical outcomes at higher costs. For our objective, we used a nationally representative database to evaluate the association between hospital safety net status and surgical outcomes in patients undergoing inpatient surgery for gynecologic cancers. For our methods, we used the 2012 through 2018 national inpatient sample to identify an estimated 288,095 patients who underwent surgery for endometrial, ovarian, or cervical cancer. Patients 18 years or older were identified using operative codes for oophorectomies and hysterectomies. Safety net hospitals were characterized as 25% of hospitals with the largest annual proportion of Medicaid or uninsured patients treated annually at each hospital. For our analysis, we used multivariable regression models to study the association of safety net hospital status with surgical approach, in-hospital mortality, acute complications, non-home discharge, and resource utilization. For our findings in Table 1, we provided a univariate analysis of safety net hospital status and non-safety net hospital status. Of the estimated 288,095 patients identified, 28.2% were treated at safety net hospitals. Compared to non-safety net hospitals, an increased proportion of those treated at safety net hospitals were admitted non-electively, identified as non-white race, and were found to be in the lowest income quartile. Safety net hospitals had a higher proportion of patients with endometrial and cervical cancer, but relatively fewer patients with ovarian cancer. Compared to non-safety net hospitals, safety net hospitals had increased unadjusted rates of open surgery while having lower rates of extended procedures and non-home discharge. In Table 2, we looked at resource utilization associated with safety net hospital status. We saw no significant association between safety net hospital status and length of stay or hospital costs in our analysis. In Figure 1, we looked at adjusted odds ratios for safety net hospitals relative to non-safety net hospital outcomes by cancer type. After adjustment for relevant variables, including hospital surgical volume, safety net hospitals and non-safety net hospitals demonstrated equal likelihood of extended operation, mortality, complications, and non-home discharge for all cancer types. Despite these findings, safety net hospitals remain associated with increased likelihood of open surgery compared to non-safety net hospitals for endometrial and cervical cancer patients. In conclusion, despite the disparities in the utilization of open surgery, safety net hospitals had equivalent in-hospital mortality, complications, and resource utilization to non-safety net hospitals. While efforts are needed to increase access to minimally invasive surgery at these facilities, safety net hospitals have shown that they are able to achieve comparable outcomes to non-safety net hospitals while caring for more financially disadvantaged patients. Thank you.